All right, welcome back again. This is second to the last lesson in abnormal psychology for IB students. Today's mini lesson is going to be discussing the use of eclectic approaches to treatment. This is Learning Outcome 5.9. And what we're going to be doing here is we're going to be examining combination approaches to treatment. In this particular case, the term eclectic simply means combinations, how we look at different combinations. We see it here is defined for you. It's being used here simply as a combination of therapies in order to achieve a particular goal. And we've kind of talked about it already with 5.7, 5.8. It's group therapies versus medication, medication in combination with group therapies, individual therapies, positive psychology or mindfulness psychology approaches to therapy and treatments, what works, what does not work, and how it comes to work. Okay, so let's go ahead and move on here. Here we're talking about the eclectic approaches to treatment of depression. Combinations, again, if I have to use the term combination, I'll use the term combination. But understand that in the exam it's going to be the word eclectic is going to be used. The most common treatment for depression are antidepressant medications. Those famous SSRIs that we've spoken about at this particular point a lot. Okay, a great deal has been discussed about SSRIs. And they are the most common. The tricyclics are probably still prescribed in some cases. I don't know the actual percentage of use today with people with depression, but a family physician had once told me that yeah, they still get a call every now and then, and I think one of my pharmacists buddies told me the same thing, that they still fill prescriptions occasionally for a tricyclic or two out there. But the most common are the SSRIs. Simply put, they relieve the depression symptoms. It may take weeks. Remember, there is a therapeutic window, upwards of about 14 days before the medication gets to a therapeutic level and the patient is able to start appreciating some relief for the medication. It's very much like antibiotics. Antibiotics have got to have a therapeutic level on them before they start ridding your body of the bacteria that needs to be gotten rid of. And that's why you take it over a prescribed number of days, is to maintain that therapeutic level within your body to combat the bacteria that you're seeking to destroy or eliminate from your body. Stopping it beforehand only builds up a resistance to that particular therapy again. And that's essentially why we're pretty much in the problem that we are with antibacterials today. There are adverse effects to any medication. Take a look at aspirin. Aspirin is a common medication that a lot of people have taken at one time or another. Aspirin's a great example. Aspirin is an antipyretic designed to reduce fever, anti-inflammatory, reduce swelling, and pain reliever. So we have these three combinations of this miraculous acetylsalicylic acid, that's the generic name for aspirin, that work to produce these wonderful things for us. But the adverse to this is that it increases bleeding time. So the more you take aspirin, the more, for simple cuts or major cuts, the longer you're going to be bleeding, because it affects your platelet buildup that stops bleeding. Platelets come to a wound and help stop the bleeding. So people that are going to be pending surgery, they're asked, do you take any aspirin products? And the older you get, you're generally asked to take an aspirin a day. Will help you for cardiac problems. But you might be asked to stop taking any NSAIDs or aspirins 10 days before, 5 days, 3 days before a surgical procedure. When I say NSAIDs, we're talking about the non-steroidal anti-inflammatories such as ibuprofen or Motrin, the brand name Motrin. So people have adverse effects to these antidepressants, and many stop taking the medication altogether. You go online and take a look at adverse effects of SSRIs, and you'll find among them a loss of appetite, among them a constipation, along with that sometimes loss of sexual function, things of this nature, disturbed sleep, suicidal thoughts. Yeah, suicidal thoughts. That's one of the funniest things I've ever seen when you see these SSRIs being advertised on television. Listen to the disclaimer that goes by rather quickly, including death. Okay, suicidal thoughts, including death. Nearly 50 to 60% of depressed patients, people with depression, okay, on an outpatient basis, meaning not being treated in a facility, being treated outside of a facility, that's why they're called outpatients, experience improvements in mood in the first trial only. Only 1 in 3 patients will experience full and complete recovery with no symptoms. This is based on the Keller study. There is a relapse rate that is high, and there is a risk of repeated episodes. That's also stated in the Keller study. What you're missing at the bottom down here, which is cut off, sorry, is that there are combinations of psychotherapy and meds seem to be valuable in decreasing the episodes of relapse. So here we have in the Keller study, it seems to suggest that an eclectic approach to treating depression, not just with medication because of the high relapse rate, but with using a combination of therapies or eclectic approaches, that we have a decreased episode of relapse. And ultimately, that's what we're trying to do is prevent the reoccurrence of depressed episodes. All right, continuing on here, we're looking at the treatment of depression by drugs and or psychotherapy. Now, when we talk about psychotherapy, we're talking about any of the others that we talked about in 5.8. We're talking about group therapy, individual therapy, we're talking about mindfulness therapy. All those therapies come under a general heading of psychotherapy. And here, the study to look at here is the Klerman et al. 1974. The aim of the study, it was a controlled study to test the efficacy of treatment, that's effectiveness of treatment with antidepressants and psychotherapy alone or in combination, eclectic again. They used 150 females, that's a good population sampling, women only. They were diagnosed with depression and divided them into 4 groups. They were given meds alone, meds and psychotherapy, no medication but psychotherapy, and a placebo or a control group doing nothing at all. And that's a good 4 good variables right there. Probably a heck of a lot of statistics to run on that one. But the study showed relapse rates were highest for placebo, as you might think, 36%. Medication alone was 12%. Individual psychotherapy alone was 16.7%, okay? And meds and psychotherapy, okay, or individual psychotherapy was 12.5%. Now here, here we have something to really consider. How does this particular statistic jive with, okay, oops, I shouldn't have used black, but there it is, okay, jive with this one right here, okay, I'm sorry, how does it jive with it? I mean, we've had other studies that show us that meds and psychotherapy, individual psychotherapy. We have a lot of statistics and previous studies that kind of say that meds alone should be a higher relapse rate than meds with additional therapy. So let's go on. Let's find here. In the next study, there was a meta-analysis for the efficiency or efficacy of drug treatment alone versus drug and IPT therapy in depression. In this particular study, the Pampalona study et al. In 2005, the aim was to analyze whether combination meds and IPT was more effective in the treatment of depression. 16 randomized control studies were conducted, including 932 patients taking meds only and 910 patients receiving meds and IPT. So all patients were randomized to their allocated treatment. This is a good sampling size, very good sampling size. But this is a meta-analysis. This wasn't an actual hands-on study. This was an analysis of combinations of studies. So they were looking at small group studies that looked at people that were doing meds alone and meds in combination with IPT, and then randomized to their treatment plan. So they had to probably go through a great number of individual studies to come up with this database of 900 and some odd, well, 1,800 people plus. The results of patients in combination therapies or eclectic treatment plans improve significantly over meds alone. This is very true. This very true in study. What? Oh, I don't know why I wrote it that way. Okay. It's a very ecologically sound study as a meta-analysis study. It ran over 12 weeks in duration. And so we have here some really good foundations, but this kind of doesn't support the previous study that we had shown you with regard to Klerman, the 74 study itself. But this one is a newer study. This is a newer study. So one might say to yourself, if you're really thinking about this, how has IPT therapy changed since 74 in the 74 study versus the study that we're looking at right now? And so we say, has IPT therapy improved or have SSRIs improved? Well, since we don't take a course in pharmacology and IB psychology, what we do have to look at here is fact. Have SSRIs improved over time? And the answer is yes, they have. The quality have, the purposefulness of the medication has improved. The adverse effects have been addressed. I don't know to what extent because everybody's different. But the bottom line here is that IPT therapy has improved, group, individual, mindfulness. All of this has been improved. It's been refined to the point where we're now able to say that there's a strong possibility that as we advance towards from 2005 towards the current time of 2016, have we seen, could we expect to see greater combinations of improvement over the long run? And the answer is probably going to be yes. So if given this question to approach and answer, because it is a level 3, remember the command term is discuss, then if I were the gambling man that I sometimes am, then I would strongly suggest that you argue in favor of eclectic therapies as a better response mechanism for helping people improve. Now remember, you can go back to 5.7 and use the data from 5.7 and the examined biomedical individual and group approaches to treatment to back up your argument here as well too. Okay. At the bottom of your study guide, if you have that available to you, there's a little blurb down there, why eclectic approaches could be more effective than medication alone. And so it goes on with these two bullets. There's always a risk that patients stop taking their medicine, okay? That they don't take it on time, that they can't afford it, things of this nature. This could be because patients feel somewhat better after a while and stop. Same is very true of people taking antibiotics. I've known many a person that when I was active duty military and in medicine, prescribing medication to my patients, I would see them 5, 6, 7 days into course, and it's a 10-day course, and I would ask them, still taking the medication? Yeah, doc. And I know doggone well the answer is no, they've started feeling better, and so they've stopped taking the medication. And they might say to themselves, taking the medication, I need this, it's going to help. But the adverse effects come in, and they come in strong. Once they start feeling better, they say, you know what, I cannot stand being constipated all the time. I stop taking the medication, I'm feeling better. But what happens is they have a relapse. in most cases. All right, I'm going to end it right there. I'll post this one, and then we will go on to 5.10, which is discuss the relationship with etiology and therapeutic approach in relationship to one disorder. And the command term there is a level 3, discuss. And that'll be the last one for abnormal psychology.